Hello and good morning everyone. I've got the TOG summary for October 2023 TOG articles for you. I hope you'll find this very valuable for your upcoming MRCOG exams. Don't forget to hit the thumbs up button and subscribe to the channel if you haven't already. So there's only 3 TOG articles to talk about in this October 2023 TOG. I hope you'll really benefit from this, and hopefully there's not too much of new information that you need to remember for the upcoming exam. So menopausal symptoms comprise of vasomotor symptoms, so things like changes in body temperature, for example, lethargy, mood changes, and genitourinary symptoms. Progestogens induce secretory transformation of the endometrium, preventing endometrial hyperplasia and endometrial cancer. They can be administered cyclically for 12 to 14 days of each month, which usually results in a regular monthly withdrawal bleed, or daily on a continuous basis to avoid the withdrawal bleed. Progestogens can be given orally, they can be given transdermally, vaginally, or as an intrauterine device. Progestogens, when given in addition to estrogen in HRT, can modify the effects of estrogen on the risk of heart disease, breast cancer, venous thromboembolism, and dementia. So you've come across the different terminology that's used mainly to talk about progesterone. The 3 terms that are commonly used are progestogens, progestins, and progesterone. Now we're going to compare and understand the difference of these 3 terms. So progestogens is a collective term for all hormones with progesterone receptor activity, including both natural progesterone and progestins. In the UK, the term progestin is not widely used. The preferred term is synthetic progestogens. Progesterone is the natural endogenous steroid hormone produced by the corpus luteum and is highly selective for the progesterone receptor. Progestins are synthetic progesterone-like steroid hormones that have similar activity to endogenous progesterone and also activate the progesterone receptor. Progestins mimic the activity of progesterone, but can also act on estrogen, androgen, glucocorticoid, and mineralocorticoid receptors. Right, so synthetic progestogens can be broken down into structurally related to progesterone or structurally related to testosterone. Now, if you go down the structurally related to testosterone route, you've got ethynylated, non-ethynylated. Ethynylated are things that include things like you've got your norethiostrone that's commonly used. You've got your levonorgestrel that's also commonly used in this group. Desogestrel, those are some of the progesterones that you may have come across. Now, if we go down the non-ethynylated route, then you've got your drosperinon. Now, if we go down the structurally related to progesterone route, you've got your derived from pregnans, derived from 19 non-pregnant, divided into acetylated, non-acetylated, and you can see examples like medroxyprogesterone there. You can see examples under the acetylated derived from 19 pregnant. You can see some of the examples there as well. So it just helps you to put the different progesterones and know exactly why they may be different, because they're actually coming from quite different routes. For HRT, the progesterones can be administered on a continuous basis or sequentially for 12 to 14 days a month. Sequential regimes usually result in a regular monthly withdrawal bleed, whereas the continuous regimes are designed to avoid withdrawal bleed, but are only suitable for women who are more than 1 year post-menopause or have had their ovaries removed. The continuous combined regimes provide better endometrial protection and may have other disadvantages, like, for example, higher incidence of unscheduled bleeding, which can continue for up to 6 months or more in the absence of any endometrial pathology. This table just talks about different ways of administering your uh, progestogen. You can also see underneath it talks about combined estrogen and progesterone um, preparations. I think you should spend a few minutes on this table and try and read off to see the different preparations. As we know, progesterone, it can be given orally, vaginally, and intrauterine. Right, so this table also talks about a continuation of the last table. Again, it's talking about the combined uh, estrogen and progestogen preparations. Again, something to be familiar for. Quite commonly in the UK, you most likely have come across these transdermal patches that your patients normally talk about, which are Everil Conti patches, Fem7 Conti patches, Everil Sequi patches. So these are quite commonly used here. Right, so unopposed estrogen have a dose and time-dependent proliferative effect on the endometrium that's associated with increased risk of endometrial hyperplasia and cancer. To prevent this, progestogens are used for at least as long as the luteal phase, which is 12 to 14 days each month, which is why the duration of 12 to 14 days. Progestogens induce a secretory transformation of the endometrium, preventing endometrial hyperplasia and endometrial cancer. They can be administered cyclically for 12 to 14 days each month, as we said before, which usually results in a regular monthly withdrawal bleed or daily on a continuous basis to avoid the withdrawal bleed. And as we said, it can be given orally, transdermally, vaginally, or as an intrauterine device. Right, so long-term safety of progestogens is very important that we talk about this. So there are four things that we're going to talk about. We talk about breast cancer, cardiovascular disease, venous thromboembolism, and dementia. So for breast cancer, estrogen-only HRT is associated with very little or no increased risk of breast cancer. However, combined HRT may be associated with a small risk of increased risk of breast cancer. The cardiovascular disease in women who are considered to have a higher stroke risk, transdermal HRT is likely to be the safest option. This can be in the form of a combined patch or alternatively an estrogen patch or gel combined with oral micronized progesterone. When used in women less than 60 years of age, estrogen-only HRT resulted in decreased rates of cardiovascular disease. The KEEPS trial, so KEEPS trial, investigated combined HRT and reported a neutral impact on cardiovascular risk markers, including the thickness of the coronary arteries and the blood pressure profile. Um, Venous thromboembolism, the risk of VTE associated with oral HRT with or without progestogen is well documented. The risk of VTE is estimated to increase by 2 to 4-fold in HRT users, and for the first year of treatment, it confers the greatest risk. The type of progesterone is so significant. It's significant. As it affects the VTE risk. Micronized progesterone and dihydroprogesterone, dihydrogesterone confers a lower risk compared with other synthetic progestogens. It is recommended that in the presence of known risk factors for VTE, including personal history of VTE or family history or a combination of transdermal estrogen and oral micronized progesterone or a combined patch offers the safest option that's unlikely to significantly increase VTE risk above the individual's background risk. Dementia, so Alzheimer's dementia is the commonest type of dementia. There's an increased risk of Alzheimer's disease with those taking estrogen and progestogen for between 5 and 9 years. Now we swiftly move on to the next TOG article, which is ECMO, extracorporeal membrane oxygenation in pregnant and postpartum women. This came a lot in light during COVID. and it's important to educate ourselves about it, because it's something that you may want to consider for your patient or counsel your patient and their relatives on it. Right, so ECMO is a form of advanced extracorporeal, which means outside the body support, used to provide prolonged mechanical, cardiovascular and or respiratory support in the context of respiratory and cardiovascular failure. The basic principle of ECMO is to drain deoxygenated blood from the body, remove carbon dioxide, and replace oxygen, and then return the oxygenated blood to either the venous or the arterial systems. ECMO should be considered in a patient with estimated mortality is in excess of 50% and is indicated when the estimated mortality is in excess of 80% as determined by the SCORE criteria relevant to the underlying pathology. So complications are numerous and can broadly be split into issues surrounding implantation of the ECMO, so cannulation, transport, medical complications like bleeding, disseminated intravascular coagulopathy, heparin-induced thrombocytopenia, and complications due to equipment like oxygenator failure, pump failure, tubing rupture. Overwhelmingly, the most frequently encountered complication is that of bleeding, owing to both the necessity of systemic anticoagulation and ECMO-induced coagulopathy. Intracranial hemorrhage is one of the most feared complications with significant attributable mortality. So MDT discussion is always necessary when these decisions need to be made. MDT would involve obstetricians, cardiac and obstetric anaesthetists, intensive care and ECMO teams, neonatologists and midwives. Overall survival rates after receiving ECMO have been reported to be above 75%, with a mortality rate decreasing over time. Approximately 70 to 75% of patients and 65 to 100% of neonates do survive. Right, so indications for respiratory extracorporeal membrane oxygenation support. So these are some of the indications like acute respiratory distress syndrome from pulmonary and non-pulmonary causes, pneumonia, severe asthma, aspiration pneumonia, thoracic trauma, acute interstitial pneumonia, diffuse alveolar hemorrhage, air leak syndrome, acute airway obstruction, peri-lung transplant. Okay, this just gives you a bit of a summary as well. So components of a multidisciplinary team discussion, so obstetric complications like premature rupture of membranes, chorioamnionitis, preeclampsia, fetal status, the well-being of the fetus, the gestation of the fetus, delivery plan, elective, and in case of emergency, what's going to be the plan, mode of delivery, time and place of delivery, maternal status, the indication of ECMO, number of days in ICU and on ECMO, vasopressors being used, evidence of clinical deterioration, comorbidities of the patient like raised BMI, asthma, congenital heart disease, and if there's any previous venous thromboembolic risk. So basically, you can see that these are the different components that the MDT will need to take into account in order to make the decision for that patient. Right, this moves us on to the third article, which is the last article of this series. Well done if you've survived so far. Don't forget to hit the thumbs up button and subscribe if you haven't already. Right, so vulval disorders in pediatric and adolescent patients and their management. This is a quite useful article also for your day-to-day practice of gynecology. You will often be called by A&E doctors, so that's emergency department doctors, to say that such and such patient's presented and it looks like a rash on the vulva or some wart-like lesions. Would you please come down and review the patient? And you need to know what it could be, what it looks like, what the treatment may involve. But more importantly, when do you need to be alarmed, which is the main thing. You don't want to miss anything in a child. So 50% of patients presenting to the children emergency department can present with vulvar symptoms. Diabetes can present with vulvovaginitis, most often caused by vaginal candida in up to 60%. Vulval manifestation of inflammatory bowel disease can precede So it can present before gastrointestinal symptoms. Vulvovaginitis can be acute and chronic condition, presenting with erythema in 82%, persistent vulval soreness 74%, vaginal discharge in 62%, and pruritus, which is itching, in 58%. Peak age is 3 and 7 years old. 80% are non-infectious causes, including dermatosis and chemical irritants. Infectious organisms in the gut or respiratory tract, like E. coli, group A strep, beta hemolytic streptococcus, and Haemophilus influenza, have been isolated in some of the cases. Vaginal yeast infections are mostly reported in the immunocompromised or diabetic children. If there's any detection of sexually transmitted disease like Neisseria, gonorrhea, or chlamydia trachomatis, then trigger automatically referral for safeguarding assessment. The pediatric population comprises of 7 to 15% of all lichen sclerosis cases. That's quite a big number of lichen sclerosis seen in children, with peak incidence in the pediatric community in the prepubertal girls. Symptoms often improve at puberty as estrogen levels rise, and 75% experience symptomatic relief at menarche. Latent relapse can happen in 2/3 of the patients. Right, so anal genital warts, and these lesions can also be seen. They're caused by human papillomavirus. Younger patients have the variant of the virus HPV 1 to 4. HPV 6 and 11 are transmitted through sexual contact and are commonest in pediatric and adolescents in anal genital warts. Transmission through heteroinoculation and auto-inoculation can occur, for example, changing or bathing with caregivers, and perinatal transmission. Sexual contact can raise concerns. Incubation period is between 8 weeks to 18 months, and the virus can remain latent for years. Well, thank you so much for listening. I hope that this summary has been useful for you. I wish you all the best for your exams. And if you are in need of some quick revision summary notes, don't forget I will post a link under this video where you could go and buy a copy of this for yourself. Hopefully, this will be the crux or the majority of the information that you will need to pass your MRCOG Part 2 exam.